Hi, and welcome to this 10-minute Tuts on an approach to bowel obstruction brought to you by the Dr. Coffee podcast. By definition, bowel obstruction occurs when there is an impedance of the movement of bowel contents. It's the failure of the contents in the gastrointestinal system to pass through distally. It could be due to mechanical or functional causes, and it can occur at any level within the bowel, and it could also be classified according to causes outside the bowel wall, within the bowel wall, and within the lumen of the bowel itself. Bowel obstruction can be a major interruption of normal physiology. Patients can die from the electrolyte derangements that occur with bowel obstruction. Feeding is a key part of survival. Obstruction is as serious as strangling a person. In fact, one of our consultants said, "Never let a sun set on a bowel obstruction." Bowels are in a constant secretory phase. There's saliva, gastric secretions, bowel, and other fluids. So a patient with bowel obstruction who isn't eating can still be vomiting all of these fluids and experiencing severe and profound dehydration. The pain associated with bowel obstruction is typically a colicky pain, where smooth muscles and peristalsis are forcing themselves against an obstruction. For example, gallstones can give colicky pain, ureteric stones can cause colicky pain, and an obstruction in the bowel can present with a similar type of waves of pain. Bowel obstructions can be either complete or partial. Partial obstructions can present with constipation as well as overflow diarrhea. The mechanism of overflow diarrhea is that stool can pull in fluid to itself osmotically, and the gut bacteria then work on feces to break it down further. This allows fluid to then pass past the stool and cause overflow diarrhea. Complete obstruction, however, will generally present with neither passing stool or flatus, which is called obstipation. These patients will always have vomiting, and it's important to ask them what they are vomiting, because fecal vomiting can occur in distal obstructions where feces is now part of the vomitus. Both partial and complete obstructions can present with pain, distension of the abdomen, and palpable feces in the bowel. Obstruction can occur at any level in the bowel. There could be gastric outlet obstruction, which we deal with in a separate 10-minute Tut, and this patient will present with foul breath, regurgitation of undigested food, and something known as succussion splash, which is the sound of stomach contents sloshing around in the stomach long after a meal has been had. The patient may or may not have abdominal distension depending on how distended the stomach is, and will typically present with epigastric pain and early satiety. Depending on chronicity, the patients may also have weight loss. Obstruction in the duodenum can also present in a similar way as gastric outlet obstruction. Lower down, bowel obstruction will typically be more bilious and less feculent if it's small bowel, but large bowel obstruction can be bilious vomiting because you're vomiting the small bowel contents as well. If the small bowel contents sit for long enough in the bowel, they can then turn from green to brown, which may be described as feculent. These patients with bowel obstruction will have dehydration and be weak from electrolyte imbalances and in a lot of pain. It's important to give them fluid resuscitation with a large bore IV line and fluids and a nasogastric tube to decompress the obstruction. Patients will immediately feel a lot better, feel less pain, and have a reduced risk of aspiration because of that NGT. You therefore reduce the risk of death due to aspiration pneumonia. So NGTs are a life-saving measure, and this resuscitation method, giving the patient IV fluids and an NGT, is known as drip and suck. Now, there are a number of ways to classify bowel obstruction. The three main ones are to classify it according to either pathology, anatomy, or the clinical picture. Bowel obstruction can be classified according to a number of ways, but the three main ones would be to classify by pathology, anatomy, or the clinical presentation. Under pathology, the obstruction may be due to mechanical or functional causes, where mechanical causes are a bowel that is moving against an obstruction, and a functional cause would be with a bowel that is adynamic or not moving at all. Mechanical obstructions can be further subdivided into intraluminal, intramural, and extramural causes, and functional obstructions can be divided into those with absent peristalsis or pseudo-obstruction. An anatomical classification would distinguish between small and large bowel, and a clinical classification would mostly be based upon the chronicity of the obstruction. Mechanical obstruction occurs when there is peristalsis working against a mechanical obstruction. Intraluminal causes occur with fecal impaction, such as in patients who are bedridden. Gallstone ileus is a complication of chronic cholecystitis or cholelithiasis when a gallstone erodes into the small intestine via a small fistula from the gallbladder. This gallstone can then lodge at the ileocecal valve and cause a complete small bowel obstruction. Other intraluminal causes include foreign bodies as well as trichobezoars, which are basically giant hairballs. Intramural mechanical obstructions can include malignancies and malignant strictures, inflammatory strictures due to tuberculosis, Crohn's, diverticulitis, or radiation colitis, as well as intestinal atresia in your pediatric population. Extramural causes of mechanical obstruction include intraperitoneal bands and adhesions, hernias, volvuluses of the sigmoid or cecum, intussusception, lymph node compression, and superior mesenteric artery syndrome. In the first world, where abdominal surgeries are more common, intraperitoneal bands and adhesions are more common than volvuluses and hernias. In the developing world, volvuluses and hernias tend to be more common. However, in South Africa, we have an interesting mix of both, where we see cases from both bands and adhesions in the abdomen from previous surgeries such as caesarean section or from infections such as pelvic inflammatory disease, as well as hernias and volvuluses being very common. Together, adhesions, bands, hernias, and volvuluses account for as many as half of the causes of bowel obstruction. Basically, the most common causes of bowel obstruction will occur from this type of obstruction, a mechanical obstruction. This includes malignancies, adhesions, volvuluses, and diverticulitis. Functional causes of obstruction occur in the absence of peristalsis without an actual obstruction in the lumen. This could be due to absent peristalsis in the case of a paralytic ileus, or failure of transmission of peristaltic waves secondary to some neuromuscular failure. It can occur post-operative due to infection, a reflex ileus, or because of a metabolic factor such as uremia or hypokalemia. Pseudo-obstruction, also called Ogilvy's syndrome, can be a recurrent obstruction, usually in the colon, that can occur in the absence of a mechanical cause or acute intra-abdominal disease. It may be idiopathic or associated with familial visceral myopathies. Other causes include toxic megacolon, which is typically more acute, or chronic colonic pseudoobstruction in the cases of things like Hirschsprung's disease, paraneoplastic syndromes, and infections such as Chagas disease. When classifying bowel obstruction by anatomy, the most common approach is to divide it into a small bowel obstruction or a large bowel obstruction. Small bowel obstruction is more common than large bowel. The most common cause of small bowel obstructions are adhesions, hernias, and cancers. The most common causes for large bowel obstruction are cancers, diverticular disease, or volvulus. High small bowel obstructions will occur with early vomiting, and the distension is typically quite minimal. However, lower small bowel obstructions will have predominantly pain in the center of the abdomen as well as central distension, and will show multiple central fluid levels on the abdominal X-ray. Large bowel obstruction will present with early and pronounced distension. The pain is a little bit more mild, and vomiting and dehydration are typically late features. In a closed loop obstruction, the proximal colon and cecum will be distended. Closed loop obstruction occurs because you have a distal obstruction and a competent ileocecal valve on the proximal end. So basically, there's a loop of bowel that is closed on either end, getting more and more distended. We can further classify bowel obstruction according to the clinical presentation and chronicity. In an acute setting, the patient will typically come with sudden onset colicky and central abdominal pain, distension, vomiting, and constipation. If this is a chronic picture, the patient will have lower abdominal colicky pain and obstipation followed by distension. This may be an acute on chronic, where the patient will have a short history of distension and vomiting against a backdrop of pain and constipation, or it could be subacute with incomplete obstruction and recurrent attacks of colic relieved by then passing feces or flatus. When taking a history from a patient that you suspect to have bowel obstruction, look out for the 4 cardinal symptoms of bowel obstruction. The first one is pain. In a complete obstruction, the pain will be constant and sharp. If there's strangulation of a hernia or part of bowel, the pain will be severe and constant. In a volvulus, the pain will be sudden and severe, and in a paralytic ileus, there will be no pain involved at all. Although obstructed, an ileus is typically not painful. Vomiting, and again you want to know the type and timing of this vomiting. Ask the patient if this is projectile, bilious, or fecal stain vomiting. The time and load of the vomiting can determine if the obstruction is proximal or more distal. A high, small bowel obstruction will typically present with greenish blue bile-stained vomit, whereas a lower small bowel obstruction will be brown and increasingly foul-smelling. Lower or large bowel obstruction does typically not present with vomiting until very late on, especially in the context of a competent ileocecal valve. Abdominal distension is a prominent feature in large intestinal obstruction. It's usually not seen in very high obstructions, especially if the patient is vomiting everything up. A closed loop obstruction will typically present with a large bulge that is hyperresonant. This can occur in the right iliac fossa, but can also be seen in the left iliac fossa. In a small bowel obstruction, the distension is typically right in the center of the abdomen. Constipation is where a patient will present not passing stool, but they're still able to pass flatus or gas. Obstipation is where neither feces nor flatus is passed, and is a cardinal feature of complete intestinal obstruction. Besides these 4 cardinal symptoms, a history is not complete without asking about previous surgeries, any features of malignancy, and underlying gastrointestinal disorders. When examining a patient with bowel obstruction, first assess their vitals. Is this a stable patient? Do they have any fever or signs of sepsis? And do they have hypotension and tachycardia, which may be features of dehydration? In their general exam, do you note abdominal distension? Do they have cachexia or any confusion? Look for signs of dehydration, such as a delayed capillary refill or a dry tongue and mucous membranes. And also remember to palpate for lymph nodes. In their abdominal exam, is there any distension? Do they have scars from previous abdominal surgery? Is there visible peristalsis? This could be a sign of severe obstruction. And does the patient have signs of peritonitis? Is there guarding or rebound tenderness? Or is their abdomen soft and non-tender? Does the patient have any evidence of masses or hernias in the inguinal or femoral regions? And do you hear bowel sounds? Initially, a patient may present with hyperactive sounds, or they may be sluggish or absent. If the patient has high-pitched tinkling bowel sounds, this could be a feature of small bowel obstruction. Succussion splash and epigastric tenderness is typically associated with gastric outlet obstruction. And as always, if you don't put your finger in it, you put your foot in it. So don't forget to do a digital rectal exam and note any masses felt, any impacted stools, and if there's any gas present in the rectum. It's important to note that small bowel obstructions may have a range of clinical manifestations. It's important to remember that unlike some other conditions in medicine, small bowel obstruction may have a range of clinical manifestations depending on the type and where the obstruction is occurring. So what investigations do you want to do for a patient with bowel obstruction? Well, first we're going to do abdominal x-rays, both erect and supine. Erect abdominal x-rays will show us air fluid levels, and in general, greater than or equal to 5 fluid levels are diagnostic of intestinal obstruction. In the small bowel, the number of air fluid levels is directly proportional to the degree of obstruction and to its site. So if there's a greater number of fluid levels, that's a more distal lesion. A supine abdominal x-ray is also better for seeing where the air is in the bowel. Different parts of the bowel look different. For example, the duodenum is typically C-shaped, whereas the jejunum may appear like a stack of coins in appearance due to the valvular conniventes. Dilatation of small bowel greater than 3 centimeters is generally considered abnormal, whereas dilatation of the colon more than 6 centimeters is abnormal, and dilatation of the cecum is generally considered to be greater than 9 centimeters. There are a number of special signs associated with the abdominal x-ray in bowel obstruction. Sigmoid volvulus can present with the coffee bean sign, which is a massive colonic distension with diluted loops of bowel running diagonally across the abdomen, typically from right to left. A cecal volvulus may present with a bird beak sign on barium enema. Intussusception, which in pediatric population can occur at many places but in adults typically occurs at the ileocecal valve, may present with a claw sign. And inflammatory bowel, such as in conditions such as ulcerative colitis, may show signs of bowel inflammation such as mucosal thickening or the thumbprint sign, or a featureless colon, also known as a lead pipe colon. Another imaging modality to consider is colonoscopy. Now, in these patients with intestinal obstruction, you're not going to want to give them bowel prep because you're just going to make their blockage worse. And anyway, they will typically have an empty bowel distal to the obstruction, so it's not necessary. Now, lab investigations in a bowel obstruction are mainly to assess complications and not necessarily to diagnose bowel obstruction. You're going to look for any derangements in the FBC that point to maybe infections or anemia, and derangements in the urea and electrolytes may be due to dehydration or intraluminal third space losses, because damaged enterocytes are unable to reabsorb fluid. Deranged UNEs may also be because of heavy vomiting, so it's important to assess for hypokalemia because this can perpetuate a paralytic ileus. On arterial blood gas, the patients may have an acidosis from bowel ischemia or an alkalosis due to vomiting. Lactate is a non-specific surrogate measurement for anaerobic respiration and may be a sign of bowel ischemia, but you need to correlate this with clinical signs such as abdominal pain if you suspect that there is ischemic bowel present. Amylase may be an important test to run in case of an acute pancreatitis, which would also present with severe abdominal pain and possibly some abdominal distension. And pre-operatively for our patients, we also want to take blood for a cross-match, a type and screen, an INR, and don't forget to do an ECG as well. In the acute management of a patient with bowel obstruction, it's important to start with your ABCs. Bowel obstruction is a surgical emergency and these patients need to be stabilized. Then you want to keep the patient nil per os. Many patients recover with bowel rest and decompression, so this is an important step. In order to decompress from the top, you want to insert a nasogastric tube on free drainage. It's important to pass a large bore nasogastric tube because a small diameter tube might get blocked up. Then, as we've said, we want to drip and suck. So the fourth part of our management will be IV fluid resuscitation. You'll want to insert a urinary catheter to monitor urine output, and remember the patient should be passing more than 0.5 ml per kilogram per hour of urine. Then we want to monitor our patient with successive arterial or venous blood gases and correct any electrolyte abnormalities as we resuscitate them. Definitive management of a patient with bowel obstruction will be determined by the cause of the bowel obstruction. In a post-operative paralytic ileus, which can occur 3 days post-op, the most important step is supportive management and drip and suck, just waiting for peristalsis to restart. You can supplement this with oral gastrographin, which is hyperosmotic and causes intraluminal osmosis and can help re-establish peristalsis. You can also give the patient prokinetic agents such as maxilon or metoclopramide or erythromycin. In a patient with sigmoid volvulus, you may consider a non-surgical or conservative decompression or a surgical sigmoid colectomy. Now, there are 3 main surgical approaches to this. The first is a sigmoid colectomy with primary anastomosis, or a sigmoid colectomy with a Hartmann's procedure and a stoma on the left-hand side, or a sigmoid colectomy and formation of a double barrel colostomy that can be anastomosed in the future. A cecal volvulus will typically have a right hemicolectomy with primary ileocolic anastomosis. A gastric volvulus will typically be treated with a gastropexy. A closed loop obstruction will usually result in surgical resection of bowel. Closed loop obstruction will typically have surgical resection of bowel, as will any patient presenting with ischemic or necrotic bowel. Bowel perforation, or the suspicion of perforation, is an indication for an emergency laparotomy. If bowel obstruction is due to hernia, well then repair the hernia with hernia repair surgery. In the management of intussusception, this will differ based on whether the patient is a child or an adult. In children, intussusception is usually due to hypertrophic Peyer's patches, and you'll want to use more conservative decompression with air or barium enemas. In elderly or adult patients, intussusception is usually due to a lead point present, such as a polyp or a cancer. Barium enemas in these patients are unlikely to work, and the recurrence rate is very high. Therefore, surgery is usually a first-line management in these patients. Remember that previous abdominal surgery is a major risk factor for bowel obstruction due to adhesions or bands later on. Therefore, in younger patients, you may be obliged to try a more conservative management rather than go straight to surgical approaches. I hope you enjoyed this short 10-minute Tuts on an approach to bowel obstruction and found it useful. If you did, hit the like button and subscribe for more 10-minute Tuts on topics in medicine and surgery. The Dr. Coffee podcast is available on Spotify, Apple Podcasts, and Google Podcasts. We'd love to hear from you, so get in touch by emailing drcoffeeza@gmail.com or following us on Instagram @drcoffeeza.